All right, guys, this is going to be your fluid electrolytes acid-base balance. This is chapter 20 or 30. Sorry. All right, so body fluid. Water is our primary body fluid. Contents varies with our age, our sex, and our adipose tissue. Water contains solutes, right? We can have electrolytes and non-electrolytes. Our body fluids and our solutes is an essential for our proper functioning of our body organs. It is made up primarily of water and contains gases like carbon dioxide and oxygen. And our solid substances called solutes that dissolve in body fluid. We have solutes, and there's two types. We have our electrolytes, and these are substances like sodium, potassium that develop an electric charge when they're dissolved in water. And then we have non-electrolytes like glucose and urea that do not conduct electricity. Our total body water contents varies with the number of fat cells, age, and sex. Women have less body fluid than men because they have proportionately more body fat. Likewise, obese people have less body fluid proportionately than those that are lean. Body fluids perform several important functions, like maintain blood flow, regulate body temperature, transport material to and from cells, serve as a medium for cellular metabolism, assist with digestion of food, and serve as a medium for excreting waste. If we deplete our body's fluids, sometimes we'll deplete our electrolytes as well. And if we replace them with just plain water without electrolytes, we can get cramps, headaches, nausea, and even confusion. So our body fluid compartments, we have intracellular, which is that intracellular fluid, ICF. And intracellular fluid is contained within the cells. It's essential for cell function and metabolism. It accounts for approximately 40% of our body. Then we have extracellular fluid, which is ECF. This is outside the cell. Extracellular fluid carries water, electrolytes, nutrients, and oxygen to the cells and removes waste products from the cellular metabolism. ECF accounts for 20% of body weight. ECF exists in three main locations in the body. We have interstitial fluid, which is the space between the body cells. Excess fluid within the interstitial space is called edema. We have intravascular fluid. This is plasma within the bloodstream. Its main function is to help transport blood cells. Then we have transcellular fluid. This includes specialized fluids such as cerebrospinal fluid, pleural fluid, peritoneal, synovial, and digestive juices. There's also third spacing. Third spacing happens during certain conditions, causes fluid to move into an area that makes it physiologically unavailable. So it's inside spaces that the body can't use it. A good example of that would be if it's in the vesicle, which would be a blister from like a burn, or if it goes into the pericardial space, which is the space in the heart, or the peritoneal space, which would be ascites. This fluid movement is known as third spacing because the fluid is literally trapped in this third compartment, not within interstitial cells or within intravascular spaces. So how does the fluid move, right? How does the fluid and electrolyte move in our bodies? We have active transport that requires energy, and then we have passive transport that requires no energy. The three passive transports are osmosis, diffusion, and filtration. We're going to look at these now. So osmosis involves the movement of the water or other pure solute across a membrane from an area of less concentrated solution to an area of concentrated solution. So water moves across the membranes to dilute the higher concentration of solutes. Recall a solute is a substance dissolved in the body fluid. Solids can be crystalloids or colloids. Crystalloids are solutes that readily dissolve, like electrolytes, and colloids are larger molecules that do not dissolve readily, like proteins. Our key point is that sodium is the greatest detriment of serum osmolality, and potassium is at greatest detriment of intracellular osmolality. Glucose and urea also contribute to our osmolality in the intracellular fluids and extracellular fluids. Right, so then when we talk about our isotonic solution, is the same osmolality as blood. Thus, no osmosis or movement of water will occur if we're giving our patient an isotonic fluid. And often given intravenously, we infuse the blood volume is low because the fluid will remain in our vascular. So then we have diffusion. Diffusion is a passive process by which molecules of a solid move through a cell membrane from an area of higher concentration to an area of lower concentration. Movement occurs until the concentrations are equivalent on both sides of the membrane. An example would be if you add cream to a cup of coffee. The coffee is initially concentrated in the area, and then when we pour the cream is concentrated exactly where it's poured. And then as it starts to be dispersed throughout the coffee, and we stir it, right? So then it's dispersed more quickly because we stirred it, and then it's equal. There can't be any more on either side. And then we have filtration. So filtration is the movement of both the water and the smaller particles from an area of higher pressure to one of lower pressure. This is hydrostatic pressure is the force created by the volume within the closed system. It's responsible for normal circulation of blood. In other words, blood flows from higher pressure arterial system to lower pressure capillaries and veins. And then we have our active, right? So we went through our three passives. Now we're on our active. Active means we need energy. So this occurs when molecules, your electrolytes, move across the cell membrane from an area of low concentration to high concentration. Active transport requires energy expenditure from the movement to occur against the concentration gradient. So we talk about ATP here. The ATP is released from the cell to enable certain substances to acquire the energy needed to pass through the cell membrane. ATP is released from the cell to enable certain substances to acquire the energy needed to pass the cell membrane. For example, your sodium concentration is greater in your extracellular fluid. Therefore, sodium tends to enter by diffusion into the intracellular department. But if we talk about the sodium potassium pump, which is located on the cell membrane, this offsets the tendency of ATP. And in the presence of ATP, the sodium passive pump actively moves sodium from the cell in the intracellular fluid and the potassium from the extracellular fluid. So now we're talking about how our body regulates our fluid. So where do we get our fluid from? Our fluid intake is predominantly from what we drink. So I'm sure we've all been told we need to drink 8 glasses of water a day, right? However, recommendations are actually that your patient should take about 2,700 for women and 3,700 for men. Our daily intake needs to be adjusted depending on what we're doing. So if somebody's doing a lot of exercising, they might drink more. If they're having caffeine, remember caffeine's a diuretic, so we have to replace even more. Situations that increase plasma osmolality, therefore promoting thirst, include excessive fluid loss, excessive sodium intake, and decreased fluid intake. And I know that if I have a lot of soy sauce from sushi, I get very thirsty, right? So by consuming that soy sauce, which is that excessive sodium intake, I'm going to have an increase in my plasma osmolarity, and therefore it's going to promote me to be thirsty. And situations that inhibit the thirst would be if we have a lot of fluids, right? Or if we're having fluid retention. If you're retaining a whole bunch of fluid, or you have an excessive amount of hypotonic solutions and a low sodium intake, your body's not really going to be craving water. So it's going to inhibit that thirst. And then how do we get rid of our fluids? So we get rid of our fluids in multiple ways, right? So we have our skin, right? We have our sweat, and that perspiration is about 300 to 600 mLs a day, and our lungs. So as we breathe, we have what we call insensible loss, and that's through the lungs as water is exhaled in our breath. And if we have a higher respiration rate, that's going to increase that 300 mLs. And then through our feces, right? Our stool contains water. If it's harder, it has less water. If it's looser, it has more water. And then our urine. So our urine accounts for the greatest amount of fluid loss. Urine output varies according to your intake, but it should be about 30 to 50 mLs an hour. So our urine volume can increase if our intake increases, and then our urine volume will decrease if we're taking less to compensate for the loss. So if we're having a lot of nausea, vomiting, and diarrhea, our kidneys are going to start to spare some of that fluid loss to make up and compensate for those. And then we have our hormone regulation. So our hormone regulation, we can start with our antidiuretic hormone, right? And this is kind of a pressure sensor in the vascular system that stimulates or inhibits the release of the antidiuretic hormone from your pituitary gland. And the ADH causes the kidneys to retain fluid if fluid volume within the vascular system is too low. So what will happen is your pituitary gland will say, hey, the volume's too low. Kidneys, you need to start to hang on to things. And that's going to be your anti. So against, anti is anti, non-diuretic, meaning you're going to hold on to it, right? And then we have our renin-angiotensin system. And this is when the extracellular fluid volume is decreased, receptors and the glomeruli in your kidneys will release renin. And renin is an enzyme responsible for the chain reaction that converts angiotensin into angiotensin 2. Angiotensin 2 will then act on the nephrons to retain sodium and water and directs the adrenal cortex to then release aldosterone. And then once our aldosterone is released, aldosterone stimulates the distal tubules from the kidneys to reabsorb sodium and to start excreting potassium. And the sodium reabsorption results in a passive reabsorption of the water. Because if we have sodium, we know we need water, thereby increasing plasma volume and improving kidney perfusion. When fluid excess is present, renin's not released, and this entire process stops. And we have our thyroid hormone. So your thyroid affects fluid volume by influencing your cardiac output. If we have an increase in thyroid hormone, this causes an increase in cardiac output, thereby increasing our glomerular filtration rate and our urine output. And then we have ANP, BNP, and CNP. All right, and this is a natriuresis, is the discharge of sodium through the urine. All three of these peptides are produced by the heart cells. In addition, BNP is also released in the brain. In clinical practice, BNP can be measured in the serum to determine the presence of your patients having heart failure with fluid volume excess. And to distinguish heart failure from pulmonary edema, the test can be performed at the bedside. So then we have our electrolytes, which is sodium, potassium, calcium, chloride, phosphorus, and magnesium. And I gave you guys the link to that if you want to watch it on your own. I'm going to pass by now. So we have our potassium, right? And your potassium is a intracellular fluid. It's only 2% of the body's potassium is found in your extracellular fluid. And I talked about in class how if we take our patient's blood, right, and those cells pops, we'll have an abnormally high potassium level. Well, if only 2% of the body is found in that extracellular fluid, if I start popping the blood cells and now it goes from inside the cell to outside the cell, that's how we have such a high number. So it's really important when we're drawing our potassium levels, we don't want to hemolyze the blood because then we'll get a false high, right? And potassium is an electrolyte and it helps with our cellular metabolism. Guidelines say that we should have about 4,700 milligrams of potassium a day. The important parts with potassium is we need to know what's considered high, what's considered low, and what's going to happen when we get our highs and lows. So our standard potassium is 3.5 to 5. And if we're less than 3, we're going to be hypokalemic. Causes of hypokalemia can be diuretic use, if they're a non-potassium sparing diuretic, if we have a lot of GI loss through gastric vomiting, diarrhea, if we're giving gastric suctioning, anorexia, bulimia, right? And our signs and symptoms of this is going to be fatigue, anorexia, nausea, muscle weakness. You're going to have a flattened EKG for our T waves, and your patient's going to have some dysrhythmias, right? So what are we going to do? We're going to monitor them. We're going to monitor our INO. We're going to monitor that potassium level. We're going to be teaching the patient about potassium supplements, encouraging foods that are rich in potassium, like our potatoes and bananas. And if we're going to have to give an IV supplement of potassium, we know that it has to be very well diluted. It has to be administered typically in a central line, and potassium always goes on a pump. Because if we have a rush of potassium, we can get hyperkalemia, right, which is going to be greater than 5. And that's going to cause your patient to have really bad dysrhythmias. They can have peak T waves, and your patient can essentially die. So we want to make sure that we never give massive rushes of potassium. We want to monitor our patient who has a high potassium level, and we need to teach them about limiting those potassium-rich foods if that's what's causing them to have high levels. And typically, if patients have bad renal failure, their body will not be able to excrete the potassium. So in those patients specifically, we need to talk to them about the dietary consideration. Other causes besides renal failure could be if they're having potassium sparing diuretics, right? Because if I'm having a potassium sparing diuretic, that means that I'm peeing out all my fluids, but I'm leaving the potassium in place. So if I'm getting dehydrated, but my potassium is staying high, right? That's how I'm going to have a high potassium. And then we also can have acidosis can cause this, major trauma can cause this. And again, hemolyzation of a serum sample can give us a pseudo hypokalemia, which means a fake one. So now we move on to our sodium. So our sodium, our normal sodium levels is 135 to 145. Sodium is found in your extracellular fluid. It regulates your fluid. If we have hyponatremia, causes of this can be diuretics, right? Because it's low, we're peeing out all of our salt. We can have some adrenal insufficiencies. We can have excessive intake of water because the water doesn't have sodium in it, so we'll dilute ourselves. Signs and symptoms of this can be anorexia, nausea, vomiting, weakness, lethargy. Your patient can end up having confusion and seizures. So what do we want to do for these patients? We want to monitor them, right? We're monitoring their I&O. We're going to monitor our sodium levels. We might increase our oral intake of sodium. We might administer IV fluid with sodium. And we're going to want to have seizure precautions on these patients. And your seizures is going to happen when you're quite low, like 192. Then we have hypernatremia. So hyper is hyper high, and causes of this could be excessive sodium intake. If you're doing water deprivation, if we have increased water loss through profuse sweating, heat stroke, diabetes insipidus, or administration of a hypertonic solution. So if you're giving too much salt in the IV, you're going to have your patient become hypernatremic. These patients are going to be thirsty. They're going to have elevated temperatures. They're going to have dry mouth. They're going to have sticky mucous membranes. And if it's severe, they can have hallucinations, irritability, lethargy. So we're going to monitor our I&Os. We're going to monitor our sodium level. We're going to want to monitor our vital signs, our level of consciousness. We're going to restrict our sodium in our diet. And we're going to be aware of hidden sodium. So hidden sodiums can occur in foods and medications that we don't realize how much salt is in them. And then we want to increase our water intake, and we want to administer our IV solutions that do not contain sodium. We have our chloride. So your standard chloride level is 96 to 106. Chloride is most abundant in the extracellular fluid. It's usually bound with other ions, especially sodium and potassium. If we have hypochloremia, we have an increased muscle excitability and decreased respirations. And if we have hyperchloremia, we can have stupor, rapid deep breathing, and muscle weakness. Our magnesium. So magnesium is a mineral. It's used in more than 300 biochemical reactions in the body. Like calcium, only about 1% of magnesium is found in the blood. The remaining is in your intracellular fluid and the bone, in combination with calcium and phosphorus. Although magnesium deficiency is rare, you can find low levels in individuals who have high alcohol intake. Some malabsorption disorders can also cause magnesium depletion. So if you have hypo, low, and our normal is 1.6 to 2.6, so low would be less than 1.6. We can have this caused by chronic alcoholism, malabsorption, diabetic ketoacidosis, or prolonged gastric suction. Our signs and symptoms are going to be neuromuscular irritability, disorientation, mood changes, dysrhythmias. This is the one that they talk about, the torsades, the tornado in the heart. So when you get in a cardiac, you'll learn if your patient has torsades. Hypomagnesium is the only thing that causes that. So if we give magnesium, it'll fix it. And we want to monitor this patient for their I&Os. We're going to encourage them to have foods high in magnesium. We're going to avoid alcohol intake. And if the patient's taking digoxin, we're going to monitor the pulse and observe for toxicity. And then our hypermagnesium, so this is going to be greater than 2.6. This is typically caused from renal failure, adrenal insufficiency, or excessive replacement of magnesium. So this patient's going to have flushing, warm skin, hypotension, drowsiness, lethargy, hyporeactive reflexes, depressed respirations, and bradycardia. And if we remember that magnesium is a muscle relaxer, it kind of makes sense that if you've made yourself really relaxed, right? We're going to have like dilation of the blood vessels. So we're going to be warm skin, and then we're going to have hypotension because that cardiac muscle is nice and relaxed. We're going to be drowsy, and our muscles are going to be relaxed. So we're going to have hypoactive reflexes, right? So everything's relaxed, whereas when it's high, everything's really, or when it's low, everything's really irritable. So the treatments for this is we're going to have to monitor their vital signs. We're going to be concerned about airway for this patient. So we might have to intubate them if we can't get their magnesium level low. We're going to have to monitor the reflexes, avoid any magnesium, and that could be in acids and laxatives and things like that. And we need to restrict their dietary intake of foods high in magnesium. So then we have our calcium. Calcium level is normally 8.5 to 10.5. Calcium is responsible for our bone health and for our neuromuscular and cardiac function. It's also an essential factor in blood clotting. So about 99% of the body has calciums located in the bones and the teeth, and the remaining 1% circulates in the blood and affects system functions. As serum levels drop, calcium leaches from the bones and into the blood to compensate. So if dietary intake is not sufficient to replace it, bone loss occurs and prolonged deficiencies can lead to osteoporosis. So our hypocalcemia can be caused by hypoparathyroidism, malabsorption, pancreatitis, alkalosis, and vitamin D deficiencies. Signs and symptoms will be diarrhea, numbness and tingling of the extremities, our muscle cramps, our tetany, our convulsions. We can have laryngeal spasms, cardiac irritability. Your most famous would be the positive trousseau. And trousseau happens, we kind of get this crampy in our arm when we inflate the blood pressure. We leave the blood pressure cuff inflated past the normal systolic. And then we can also have chevauchetics, which is when we stroke the face or tap the face and we get facial twitching. And it's up at that part of the jaw closer to where your ear is if we stroke there. Our treatments for this is we're going to want to monitor our INO. We're going to monitor our serum calciums. We're going to increase and encourage calcium intake and supplements. And we're going to, if it's severe, monitor for airway patency, concerns for seizure, precautions, and safety. If we have hypercalcemia, so too much, right? Greater than 10.5. Causes of this is if you have hyperparathyroidism, some malignant bone diseases, prolonged immobilization, excessive calcium supplementation, or a thiazide diuretic can do it. So your signs and symptoms are going to be muscle weakness, constipation, anorexia, nausea and vomiting, kidney stones, bradycardia, sometimes bizarre behaviors, right? So again, we're going to monitor our patient's INOs. We're going to encourage fluid intake to prevent stone formation, because your patient can get kidney stones. We want to encourage fiber to prevent constipation, and we want to eliminate calcium supplements and limit the amount of calcium-rich foods they have, and avoid calcium-based acids. And if it's really bad, the patient might require dialysis. So then we have our phosphorus. So our normal phosphorus levels are 2.5 to 4.5. Phosphorus is a intracellular fluid. It is helping us maintain bones, teeth, plays a major role in our acid base, and it promotes energy. So if we have a low phosphorus level, it can be caused by feeding after starvation, alcohol withdrawal, diabetic ketoacidosis, or respiratory acidosis. This patient is going to have joint stiffness, seizures, cardiomyopathy, impaired tissue oxygenation. And we're going to monitor for serum phosphorus level. And we might need to monitor the calcium levels as phosphorus is replaced. Because remember, these two mirror one another. So if the one's going up, the other one's, I guess they don't mirror, they're the opposite. If one goes up, the other one goes down, and vice versa. So we need an even balance of both of them, because as the phosphorus gets lower, the calcium is going to get higher. Okay, or that's it. And then if we have hyper, so too much, hyperphosphatemia, greater than 4.5, this can be from renal failure, hyperthyroidism, chemotherapy. This can cause short-term memory, tetany, calcifications in soft tissue, right? And we want to monitor our phosphorus levels. We want to monitor the patient for tetany. We want to administer albumin, and that's that. So we have our bicarbonate. So bicarbonate is present in both your intracellular and extracellular fluid. The kidneys regulate your extracellular bicarbonate to maintain an acid-base balance. When serum levels rise, the kidneys will excrete excess bicarbonate. If serum levels are low, the kidneys are going to conserve it. So your acid-base balance, your acid is a compound that contains the hydrogen ions. The base is a compound that accepts hydrogen ions. Amounts in solutions are reflected by the pH. An acceptable pH is 7.35 to 7.45. And we measure this by an arterial blood gas. So by an arterial blood sample, so where your pulses are, that's where you can get an arterial sample. So our acid-base regulations, right? We have our buffer system, which is to prevent wide swings in your pH. So wide springs would be your pH going from 7.1 to 7.45. Right, this is a buffer system that consists of a weak acid and a weak base. And these buffer molecules keep strong acids and bases from altering the pH, either by absorbing or releasing free hydrogen ions. Then we have our respiratory mechanism. So your lungs are the second line of defense to restore a normal pH. They control the body's carbonic acid supply via carbon dioxide. So we either remove it or we retain it. So when the serum pH is too high, which would be too, serum pH is too acidic, it's too low. I'm gonna stop and start, right? So when the serum pH is too acidic, your pH is low. It's gonna be less than 7.35. The lungs remove carbon dioxide through rapid deep breathing. This reduces the amount of carbon dioxide available to make carbonic acid. If the serum pH is too alkaline and the pH is too high, so greater than 7.45, the lungs try to conserve carbon dioxide through shallow respirations. This system works with the carbonic acid, sodium bicarbonate buffer system to maintain the 20:1 ratio of base to acid. The last line of defense that we have is the renal mechanisms, right? This is our kidneys, which regulate the concentration of plasma bicarbonate. They can neutralize more acid and base than either the respiratory system or your chemical buffers. If the serum pH is too acidic, then the kidneys conserve additional bicarbonate to neutralize the acid. If the serum pH is too alkaline, the kidneys excrete additional bicarbonate to lower the amount of base and thereby decrease the pH. The kidneys also buffer pH by forming acids and ammonia. Right? And ammonia is a base. Although the renal system is very effective at altering pH, it's also very slow. It can take up to 3 days to return the pH to normal limits. This process is known as compensation. The pH returns to normal, but the carbon dioxide and bicarbonate levels are still going to be abnormal. So talking about deficits or lack of fluid, right? We have hypovolemia, and this is when there's just not enough fluid. So we have a loss of blood volume, and this would be hypovolemia. And dehydration describes a state of negative fluid balance in which there is a loss of water from the intracellular, extracellular, or intravascular spaces. Weight loss of a sudden 5% loss of body weight is clinically significant. When the loss approaches 8%, fluid loss is severe. A sudden loss of 15% of body weight due to fluid loss is usually fatal. The patient with fluid volume deficit usually has an elevated B1 to creatinine ratio and an elevated hematocrit. Both values increase because there is less water to proportion to the solid substances being measured. So if we had a patient with hypovolemia, we would expect them to have weakened threading pulses, right? They're going to be tired. So we're going to be giving this patient IV fluids. Typically, it's going to be that isotonic fluid, so it's going to be a normal saline. We'd want to monitor the patient's nose. We want to encourage them to have an oral intake. We want to monitor their electrolytes, and we want to do daily weights on them. And again, the assessment on this patient is going to be dry skin, dry mucous membranes, decreased outputs. They could have an increased heart rate, and they could have that rise in temperature, and they're going to have those weak thready pulses. So when we have a fluid volume excess, too much is hypervolemia. This involves excess retention of sodium and water in the extracellular fluid. Fluid volume excess can result from excessive salt intake, disease affecting kidney or liver function, or poor pumping action of the heart. The retained sodium increases the osmotic pressure in the extracellular fluid, thus pressure pulls fluid from cells into the extracellular fluid. Your signs of your patient that has your fluid overload would be an elevated blood pressure. These guys are going to have a bounding pulse. Respirations are going to be increased and shallow. Our neck veins could be distended, so we're going to have JVD. We're going to have increased intravascular volume, which can also cause us to have excessive extracellular fluid that may accumulate into the tissues and cause us to have that third spacing and edema. The skin could be pale and cool. Our urine output's going to become diluted. The patient will rapidly gain weight in this severe fluid overload. The patient's going to develop moist crackles. They're going to have shortness of breath and dyspnea, and they're going to have ascites, which is going to be that excess third spacing peritoneal fluid. Hypodilution will cause the BUN, the hematocrit, and the specific gravity of the urine to decrease. So now we're going to talk about acid-base imbalances. So we can have either respiratory acidosis or metabolic acidosis. So anytime we have acidosis, it's going to be that pH that's going to be less than 7.35. And if your patient gets all the way down to 6.9, that's incompatible with human life and usually needs to die. So respiratory acidosis can be caused by conditions or medications that impair gas exchange at the alveolar and capillary membranes. Our depressed respiratory rate and depth, or an injury to the respiratory center of the brain. So our signs and symptoms in the acute phase are going to be increased pulse and increased respirations. Patients could have a headache, they're going to be dizzy, confused, decreased level of consciousness, and they're going to have some muscle tension. The chronic patients are going to have headaches and weakness. Your interventions for these are going to be providing pulmonary hygiene, so suctioning and vents and things of that nature. We're going to have to institute measures to improve gas exchange, such as chest physiotherapy. So that's when we're tapping on their chest. We might do bronchodilators. We might need antibiotics. And we're definitely going to want to provide supplement oxygen, and we're going to want to maintain hydration. So then we move on to our metabolic acidosis. So your metabolic acidosis can be caused from retained acids in the blood by renal impairment or poorly controlled diabetes or even starvation. Usually when we have patients that come in with pretty significant metabolic acidosis, it's usually our non-compliant DKA patients, right? Because that's diabetic ketoacidosis, if you've ever heard of that. So those are our patients that we see with these really low pHs. These conditions will decrease the bicarbonate, such as excessive GI loss can also trigger a metabolic acidosis. And if you think about your patients, well, never mind. We haven't gone up with DKA yet. So, all right. Other causes that can create this is excessive intake of acids. So if your patient has a lot of aspirin poisoning, this can do it. Your signs and symptoms are going to be headaches, confusions, drowsiness, weakness, peripheral vasodilation, nausea, vomiting. This is going to be Kussmaul breathing, so it's going to be rapid, it's going to be deep, and that's frequently associated. They also have high kalemia, so high potassium. And your treatment for this is going to be directed at correcting the underlying problem. And a lot of times we're going to start to give them bicarbonate, because if we give them bicarbonate, it should help reduce the acidity and make them more alkalized. So then we have our alkalosis, right? And we can have a respiratory alkalosis and we can have metabolic alkalosis. So our respiratory alkalosis can be caused by hyperventilating, resulting from anxiety, fear, sepsis, lesions in the brain, and anything that can cause excessive ventilation. So if your mechanical vent is causing your patient to breathe too fast. Signs and symptoms of this is going to be confusion, difficulty focusing, headaches, tingling, palpitations, tremors. Our treatments is going to be to, reduce that anxiety, slow that breathing, and identifying and treat the underlying cause. And then our metabolic acidosis can be caused by excessive acid loss. So vomiting, gas extraction, use of potassium-wasting drugs, diuretics, hypokalemia, excessive bicarbonate intake, and even hyperaldosteronism. So your signs and symptoms of this is also going to be the dizzy, the tingling of the extremities, hypertonic muscles, decreased respiratory rate and depth. So your treatment is going to be directed again at correcting the underlying problem. Treatment often includes administration of sodium chloride solutions or sodium-rich fluids. So now we're going to go on to how to interpret an ABG, right? So there's 4 steps, and you guys all watched the video. But the first thing that we want to do is we want to examine our pH. So these are pH, acidotic, alkalotic, or normal. If it's acidotic, it's less than 7.35. If it's alkalotic, it's more than 7.45. And if it's normal, it's in between 7.35 and 7.45. Then we want to check the amount of carbon dioxide. Carbon dioxide, luckily, is also 35 to 45. And then we have our bicarbonate, which is the best years of our life, 22 to 26. So is it too much or is it too little? And then compensation. And I'll show you guys compensation, but you're not going to be required for compensation. So example of our acidotic, right? Is it pH too low? Is it too high? Or is it between? And the key point is not to forget that a pH is neutral if it's 7.4. It's very important when we discuss compensation. It's not really important at this point. So then we want to check the amount of carbon dioxide, right? So if it is less than 35, there's too little, and then this is an alkalosis. And if it is too much, then it's an acidosis. Or is it normal? Is it between the 7.35 and 7.4? And the same thing with this, right? If there is too little of our bicarbonate, it's acidosis. If there's too much, it's alkalosis. So step 4 is it compensated? Is it partially compensated or fully compensated? So no compensation is that the pH is abnormal. So that's super easy. Partially compensated, right? So if we're partially compensated, the pH and one ABG component are abnormal. The second ABG value is starting to change, or the pH is moving towards normal. So an example would be if the pH is 7.32, the PCO2 is 50, and the bicarb is 28. Although the pH is increasing, so it's not lower than 7, it's just a little bit lower than 7.35, right? The PCO2 still remains high. And the bicarb is increasing to alkalosis to bring the pH closer to normal. So this probably would be better if we had multiples, but the slides just have one. And then we have our fully compensated. So the pH returns to normal and the other ABG components are still abnormal. And again, guys, you're not going to have to tell us whether it's fully compensated or partially compensated. You just need to know if it's acidotic or alkalotic. And again, if we're doing treatment for a patient and our ABG has improved, then that means that the therapy that we've chosen is working. If we're doing treatments for patients and our ABGs have gotten worse, then the treatments are not effectively taking care of them. And that's what we need in fundamentals, is to understand that. So your nursing assessment includes cues for a fluid electrolyte acid base imbalance, right? We're going to start with our assessment. We're going to want to do our head-to-toe assessment. We're going to know what our vital signs are, our temperature, pulse, respiration, blood pressure, even pulse ox. We want to make sure that we're doing daily weights on these patients. We want to do a fluid I-NO, right? And this is going to be a strict I-NO. We're going to do lab studies. We're going to do a complete blood count. We're going to do our CMP, which is our comprehensive metabolic panels. We're going to monitor our ABGs. We're going to want to be looking at our urine specific rapids. Different types of nursing diagnoses that these patients can fit into could be a fluid balance, so too much, too little, risk for too much, risk for too little, risk for an imbalance, and then our electrolytes, right? We can have an impaired gas exchange, or we can have a risk for an electrolyte imbalance, or we can have an actual imbalance. So when we're planning our outcomes, right, the overall goal for the patient experiencing any of those problems would be to restore our balance. So we might need to promote hydration, right? So our planned outcome would be that our patient's going to be hydrated, that our acid base is going to be balanced again, and that our fluid's going to be balanced again. So your nursing interventions, what are you going to want to do? We're going to want to do a lot of dietary teaching, right? Because we know that all of those electrolytes can be affected. So we want to promote fluids if that's appropriate. We want to do electrolyte balanced diets. Most people need to limit their sodium intake and increase their dietary potassium and calcium. But again, this would all be contingent upon what's going on, what electrolytes abnormal, how we're correcting it. If we have somebody who's hypovolemic, right, and so they're low, if they're low, we're going to want to encourage them to take fluid in, right? So we might do, hourly goals, and we might get their family involved in it, and we might have them do tracking so that we know how much they're taking in. Whereas maybe your patient has too much fluid, and instead we need to limit the amount of fluids they take, and we need to monitor how much they're putting out. So we might, teach the family that, okay, we have this device in the toilet to measure their urine, and only the patient can pee in that. And nobody else can pee in that. Nobody needs to dump that without making us aware of how much they put out. So you have to be creative, and you have to think about, what's going on. So what intervention would be appropriate? If we're talking about fluids, right, we have these different types of fluid solutions, which we'll learn more about in MedSurg 2. But if it's an isotonic fluid, that fluid remains in the intravascular compartment. So an example of that would be normal saline. And then we have hypotonic solutions, which pull body water out of the intravascular compartments, and hypertonic that pulls water into the intravascular department. We go on to our types of vascular access. Okay, so if we need to give somebody fluids or medications, right, how are we going to give it to them? So we can have peripheral access, which would be like a peripheral vein. And then we can have central access, which is going to be in a larger vein. And then we have interosseous, which is going to be into the bone. And then we can also have our subcutaneous fluids. And we know that if we have essential access, these are going to be a more major vein. It's typically in your subclavian, your internal jugular veins sometimes used. And these larger sites can accommodate all types of IV solutions. Whereas your peripheral vascular, we have to be careful of caustic medications that can actually destroy those veins. And then there's also the subcutaneous. And we're going to talk about that more on this side. So your subcutaneous infusions, right? We can use these with kids. They're good in our home-based and palliative cares. We're typically going to be using the abdomen, thighs, back, and those areas. And the advantages of this is that it's low in cost, it's an ease of application, and it has minimal infections and complications to it. So local complications that can occur due to IV therapy, we have hematoma, and hematomas are a localized mass of blood outside the blood vessel. And so it's like a little ecchymotic spot. A lot of people will call it site trauma. We can have infiltration. So infiltration would be if it's a non-vesicant solution into the surrounding tissue. It'll typically cause swelling, pallor, hardness, and coolness of the extremity or the site. And we need to stop the IV. And this is when we typically need to restart it in a different extremity or in a higher site. And then we have extravasation, which is seepage of a vesicant substance into the tissue. So it's pretty much the same thing as infiltration is, except infiltration occurs with a non-vesicant, and this is a vesicant, and the vesicant is going to cause pain, burning, blistering, and tissue damage. Vesicants typically will need an antidote to be instilled. And if the antidote's not instilled, your patient can lose their extremity. And then we have phlebitis. So phlebitis is inflammation of a vein. It's going to be redness, pain, and warmth at the site. There's local swelling. You can have a palpable cord along the vein, sluggish infusion rates, and elevated temperatures. We're going to have a slowed or stopped infusion, localized warmth. And then we have thrombophlebitis, which is thrombus and inflammation. Again, you're going to have a sluggish flow rate. You're going to have edema. You're going to have a tender and cord-like veins. You're going to have warmth, and you're also going to have erythema at the site. And that's because it's not just the inflammation and irritation, but now there's a clot there. Then we can have our localized infection. So this is just a microbial contamination of the cannula or the IV site. You're going to have some redness, you're going to have some swelling. Now you're going to have exudate, and you're going to have an elevated blood temperature. And then we have our nerve injury. So nerve injury is inadvertently injured during the venipuncture. It can be direct, and if it's direct, it's going to be an instant sharp pain like an electrical shock. And then we can have a compression. So a compression injury to the nerve is typically 24 to 96 hours after the puncture. So, you know, if we start an IV in the ER and it's working fine, and then the patient starts to have that discomfort, that's because of the nerve is slowly being compressed. Then we have our systemic complications. So your systemic complications from using access, right, can be, right, systemic is going to be the whole body. Multiple systems can be affected. And the first one that we're going to talk about is septicemia. So septicemia is sepsis. And this is the presence of microorganisms or the toxic products that are in the circulatory system. The patient's going to have fevers, chills, tachycardia, confusion, hypotension, altered mental status. They're going to have elevated white blood cell counts. So you can see how with this septicemia, right, you're having confusion, so your neurological system is involved. You're having tachycardia, so you're going to have your heart involved, the cardiac. So it's a whole body is affected by it. And then we have fluid volume overload. So fluid volume overload we know can be because we gave too much fluid at once or we gave too much fluid too fast. So we're going to have, right, that's that hypervolemia. We're going to have edema, hypertension, shortness of breath, crackles, JVD, the distended neck veins. And the biggest thing that you're going to want to do if your patient's going into fluid overload is you're going to want to turn the fluid off, right? Because the cause of this systemic complication is because there's too much fluid going. And then we have our air embolism. Our air embolism is going to be because there's air in the vascular system that doesn't belong there. So if your IV site had a whole bunch of air in the tubing and you pushed all that air into your patient, you're going to have an air embolism. We introduce air to patients when we do a TEE to see the bubbles, to see if the bubbles are crossing and that septal wall in the heart is not patent. So if your patient goes for a TEE and he gets, 2 to 3 cc's of air because of that, and then you give half a tubing of air into them, well, now you could have an air embolism. So what's that patient going to have? They're going to have palpitations, they're going to have chest pain, they're going to have lightheadedness, they're going to have shortness of breath, cough, hypotension, tachycardia, sudden change in mental status. Again, lots of different systems being involved. Right, and then we have a catheter emboli. Remember I talked about in class how when we're inserting an IV catheter, it's a little plastic catheter and there's the metal needle on top of it. And as we're kind of threading that catheter in, if we decide to bring that catheter back over the needle, we can't see inside, so we don't know if maybe that sharp actually made that catheter end jagged and shot a piece of that plastic off. And if a piece of that catheter is cut off, is now going to be running through your patient's circulatory system, right? So if it ends up shooting into the lungs, it can cause shortness of breath. If it ends up getting lobs through the chest, it can cause chest pain. You get tachycardia, hypertension. So definitely something that we do not want to do. And your septicemia, your air embolus, and your catheter embolus are all things that are reportable offenses to our governing bodies. So you don't want to be involved. All right, now we move on to blood, right? So blood, if we have somebody who's hypovolemic, right, and they've lost blood or they need blood to be replaced, because as we said in the beginning, if I really deplete my system a whole bunch, I don't want to replace it with just plain water. So sometimes we have to replace it, right? So if I'm an athlete, I'm doing a lot of exercise and I'm sweating it out, I'm going to become hypovolemic. But in that case, normal saline, salt water, that isotonic solution, should replace it just fine. But if I'm somebody who's lost a lot of fluids because let's say I'm septic, and I've burned off all my fluid reserves, well, then I might need more fluid replacement. And if we give too much fluid, we're going to dilute our blood. And we don't want to dilute our blood because we know that our blood is what carries our oxygen on, right? So if we just replace with tons of normal saline, right? We're just giving saline. Well, then what's going to happen to my hemoglobin, right? My hemoglobin is going to be way too diluted, which means that I'm not going to get oxygen to all the parts of my body. And then also we could deplete our other factors in our blood that keep us safe, like our clotting factors and stuff like that. So sometimes we have to give blood products to people that are very hypovolemic, right? And if we're giving blood, we have to be very careful with how we administer it. So the first thing that we need to make sure is we need to make sure that our patient is typed and crossed. Every patient should have a type and cross, right? And we're doing that to see what type of blood they have. Do they have A? Do they have B? Do they have O? Do we have AB? And is it positive or negative, right? Because positive blood can receive negative blood. Negative blood cannot receive positive blood. And then A can only have A, B can only have B, O can only have O, but AB can have A, B, and O. I'm sorry, you know what? And A can have O and B can have O. O can only have O. So our important point is that AB is the universal taker and O is the universal giver. Okay, so if you're the universal giver of O, you can only have O. So if you are O negative, you're the hardest blood to receive, but O negative can give to anybody. O positive can give to anybody who has positive blood type. And again, this is just an awareness level. You guys really are not going to need to know necessarily this right now. And you'll be learning more about this in MedSurg too. Our blood products that we have, right? So we have different types of blood products. Blood always needs to be hung with normal saline. It can never go with anything else because any other fluids can cause the blood cells to actually break down or clump up, and then they're not going to be effective for your patient. Platelets help your body to clot. So if we give a lot of different blood products, we're going to have to make sure that we replace platelets too, so that our patient doesn't have bleeding issues. And then the nursing interventions for blood is what you do need to know. So when we're replacing blood, we need to obtain a set of vital signs beforehand. And the reason that we get vital signs beforehand is so that we know that it's safe to administer our blood. We need to make sure that the patient has a patent IV site. And we want to remain with our patient. Your book says for 5 minutes, but in professional practice is really for 15 minutes. And the reason that we do that is because the majority of our transfusion reactions are usually going to happen within 15 minutes. So So we say 15 minutes. And if our patient starts to have a transfusion reaction, we're going to want to stop the blood, because if they're reacting to it, right? And just like anything else, if we're having a reaction to something, we're not going to want to continue to give it, because the more we give it, the worse the reaction is going to get. So we always want to assess the patient, stop the blood, assess the patient, notify the physician, right? Our different types of transfusion reactions we can have. We can have an allergic reaction. So the allergic reaction is because your body has an allergy to the blood or to an additive that was added to the blood. Your allergic reaction is going to be flushing, itching, wheezing, urticaria, which is hives, and it can be as extreme as anaphylaxis, right? And then we have bacteria. So bacteria reactions is typically because the blood was contaminated in some way. So this is going to be a fever, a chills, a vomiting, diarrhea, and hypertension, high blood pressure. And then we can have our febrile reaction. So febrile is a temperature elevation, and it's typically due to a sensitivity to the white blood cells, the plasma proteins, or the platelets in the blood. We can have a hemolytic reaction. Hemolytic reaction is probably one of the worst reactions, and that's because there's a destruction of the red blood cells as we're infusing, right? So this means if we're having a hemolytic reaction, that your patient received blood that was not compatible with them. So our typing cross was not correct. So maybe we gave the patient the wrong blood, maybe we picked up the wrong blood from the pharmacy, from the lab. Something happened that we're having incompatible blood. It usually only occurs in 1 in 6,000 transfusions. And then we can have circulatory overload. And remember, circulatory overload is hypervolemia. This is too much volume. You're flooding your patient, right? So it can either be that we gave too much blood or we gave blood too rapidly. So this patient, what are they going to have? They're going to have the JVD. They're going to have the Crefts. They're going to have all those fluid overload symptoms, the high blood pressure, the rapid breathing, all of that's going to happen with circulatory overload. Okay. So if this happens, we want to stop the transfusion. We want to call, we want to stop the transfusion, assess our patient, call the provider, treat the symptoms, and sometimes you might need to call a rapid response on these patients. And that is the end of your electrolytes. And I have added this acid base to available hyperlinks for you guys. And I added the ABG tic-tac-toe interpretation as a hyperlink. And this one, acid-base disturbances pathology, is also added, and you might find that helpful. You might not. All right, that is all for this lecture.